I'm Dr. David Dodwell. I'm a clinical oncologist, and I've become involved in the national audit in metastatic breast cancer, shortened to the NAoMe audit, which we're just trying to get up and running at the moment. Well, the audit is, put it simply, it's to look at the care that patients with metastatic breast cancer are receiving, both in England and in Wales, that are the two geographies we're involved in. It's to look at that process of care. It's to try and identify where there are shortfalls in that care that we can consider and look at addressing. And of course, this applies to the management of patients with secondary breast cancer. It needs to be done carefully, and one of the most important things with the audit is that we take input from a whole range of different people. I don't like the word stakeholder, but it's always the one that springs to mind. And of course, that includes very firmly the patient voice as well. So we have to make sure that what we do is relevant to patients and that they have a major say in what is important in the management of those patients with this difficult disease. And so there's quite a lot of discussion that needs to go on with patients, with the charities, with the specialist nurses, with all the medical disciplines that are involved in treating patients with breast cancer and managing them. And that takes quite a while. The other thing we do have to do is we have to make sure that the things that we want to do are actually practical. You have to have things that are easy to categorize and to quantify. And some of the aspects of the management of patients with metastatic breast cancer don't fall easily, into that category. So, for instance, one might want to ask the question: well, what did you feel in terms of the availability of support services to manage symptoms, for psychological support, for social support, for help with finances? Well, those things are important, but unfortunately, there's no easy data source that provides us with that information quickly and simply. So we have to focus on what's important to patients particularly, but to all of us that are involved, but also what's practical. So particularly from the patient angle, we're looking at concerns about the support that they're offered. And perhaps the most tangible aspect of that is to ask the question, is there a specialist nurse who's particularly skilled in helping patients with secondary breast cancer? And that's clearly a deficit in many areas. So that was felt to be really important to patients. In terms of what the clinicians, particularly oncologists, thought, it was more about access to particular treatments. Is drug X available widely? Is there some issue with availability, postcode prescribing, etc.? And then in and amongst that, we did identify some specific groups of patients that were felt to be more disadvantaged. And actually, interestingly, those seem to be patients at the extremes of age. So not just the younger patients, but also older patients. And in terms of younger patients, it's issues and concerns about fertility, about cosmetic results in the short term, about the difficulties of menopausal symptoms following treatment. And in the older patients, it again relates mostly to support services that were available, and also the fact that older patients do seem to be relatively disadvantaged. They're not requested to come for routine screening. They do have a higher risk of breast cancer, which is very dependent on age. So the incident rate of breast cancer increases very much in older patients. And they have been hitherto perhaps a disadvantaged group. And then there were some types of breast cancer that were felt to be a priority. And one of those, probably the key one, is patients with triple negative breast cancer. And that's particularly because for all patients with breast cancer, you can use chemotherapy treatment. But for patients with triple negative breast cancer, up until very, very recently, it was the only treatment that was available. So that's difficult for them. And the other issue with this group of patients is that they do have a poorer outcome than other groups. So we've picked those up already as a group of patients that are at particular disadvantage. And then finally, patients who develop brain metastases. They have a poor prognosis, and treatment for those patients is really very difficult. And in many circumstances, only on the margins of being effective. So there is a big unmet need for both of those patient groups. National audits, by definition, are to look at national figures. It's not enough to know that one hospital is particularly skilled or doing well in particular treatments. We want to look at the whole range of population. So we're not just covering the types of breast cancer, the age ranges that are concerned, but also we're looking at geographical access. We have a difficulty in that patients with secondary breast cancer are very much off the radar as far as the cancer registries go. So when a patient presents with a new lump in the breast, a new primary breast cancer, that diagnosis is registered in the national cancer registries. But when that patient, or if that patient is unlucky and develops secondary breast cancer some years down the line, the cancer registries do not automatically record that. And so there are ways and means that we're trying to develop, or at least consider, to try and get around these problems. But the main reason to do it is to look at the totality of the population. And within that, of course, includes groups of patients who perhaps in many other circumstances would not easily come to attention, disadvantaged patients, patients who live in socially deprived areas or on low income, other minorities for other reasons, don't often feature very, very readily in other work, but we need to try and include them within the national picture if we can.